So good morning, everyone. We're going to just let the last couple of stragglers come in just because it's 8 a.m.
On the first day.
On the first day. And we're debating on using the microphones or not because we're either program directors or associate program directors, so we're used to raising our voices and projecting, but never, ever. But at this hour, at least I thought I would try to go. So thank you for coming to our 8 a.m. session on trying to figure out how to be an educator in a boarding situation and optimizing our resident education and wellness. And I'd like to introduce myself. I'm Leah Bright. I'm the Associate Program Director at Johns Hopkins.
I'm Katya Goldflam. I'm an APD at Yale.
I'm Cassandra Brivey. I'm the Residency Program Director at East Carolina University.
And I am Rebecca Merrill, and I am the Program Director at Cleveland Clinic Akron General.
So that's all. So between us, we all have quite a bit of experience, theoretically, on how to try to educate residents in challenging times, which I think we can all understand right now. So when we kind of started this talk, we wanted to talk about what is a boarder. I think we all have different ideas of what that means. So by the Joint Commission, essentially means a boarder is someone who's remaining in the emergency department 4 hours after admission time. I think we're all aware of this metric, right? That you're supposed to get the patients upstairs within 4 hours of admission, which seems like a very long time, but apparently it's not. And we also know that it is also a challenge and has been for quite some time. Obviously, we all know that boarders create ED crowding, and the need for, which essentially means that the need for emergency services is exceeding the available resources for patient care. Very simply put, I think we all understand that too. But we also know that boarding leads to significant patient harm and delays in treatments for ill patients. I'm sure we could all tell horror stories about the code that happens in the waiting room and increased adverse events and preventable errors. So there is no plus side to boarding. It's all negative. If someone has a plus side, please tell us. We'd love to know. Just trying to find one. So who are the educators and who's impacted by this? Well, we're all impacted by this because education, obviously, especially emergency medicine, is affected by boarding. And the residents are affected, and the medical students are affected, and the nurses are affected, and the medics are affected. I don't know, in our institution, we end up having our poor medics waiting for hours in our hallways because they can't unload their patients off the stretchers. And we are trying not to use chairs. We are using chairs, but it just ends up being a huge bottleneck. So boarding and educators, this is obviously why we're all here today, right? Who are we and what we are not? We're not admin. So this is obviously, we can talk about this all day, boarding, educating, administrative goals. And it's been an issue for many of us in unprecedented ways. Even when the patient volumes went down with COVID, we still were boarding ICU patients for 5 days in our ER. Don't tell anyone I told you that Johns Hopkins was boarding ICU patients in their ER for 5 days. They will deny it. But it was a real challenge for us, and we couldn't get our patients anywhere. And for us as physicians, it was challenging. And what does it mean for education of our residents? Obviously, we come down to a slowdown, right? If you are not moving patients, how do you teach a resident to actually see the patients and do quick assessments and correct assessments if the same patient's been in the same room for the last 3 days? I can probably teach them how to be a good ICU doctor, though both of us struggle on that. But we're trying to figure out what labs to order, and in our institution, no, medicine does not take over the inpatients, so this was even more of a stress on us. We were taking care of the inpatients. Don't tell anyone that either. So it was a real challenge for us to try to take care of these patients and actually find a way to educate our residents and make this valuable for their time and not more stressful. So our overview of our talk, the boarding landscape, which I think we all understand, the impact on education, what we are seeing nationwide survey data. So our question was, in our meetings, were we the only ones that were affected by this? Or is this a national problem? Which we guessed it probably was. We wanted to hear what our colleagues had to say. And what are we doing? How are we trying to flex for this? What are we innovating? How are we trying to make this somewhat a good experience for our residents? The challenges that we're facing and some of the recommendations. What do we come up with and what have our colleagues come up with to try to cope with this situation? So the current landscape, ED visits are up 60% since 1987. Now, I know we all saw a lull during COVID. I don't know how many of you, but we have seen a spike again. We are going up, and we are at pre-pandemic levels, if not higher some days. And then we're seeing it's like 48 visits per 100 people. 90% of ERs at this time, or EDs, are identifying as being stressed beyond a breaking point. This is prior to COVID-19, and from what I understand from my metrics people at Hopkins is that we're seeing the stress again. And again, it's the current status is your inability to respond during a public health crisis. Hello, that was probably what we all faced, right? Like all of a sudden we weren't able to flex to the influx of patients. And how are we going to handle that? And of course, it always lands on the ED to try to figure it out. So does anyone have this? This is like your hospital census of your 85% or less than 85, the hospital runs smoothly, your patients are going upstairs, you wonder if there's a full moon because what's happening. And then here, you're kind of a little bit of a slowdown, and then where we tend to hang out, sorry, I'm gonna get blinded over here, is hospital census is over 90%, and all of a sudden everything comes to a screeching halt. And this is when all of the colors show up on your boards. I don't know what you guys have, we have black. And we're on plaque status, now we're on purple status, now we're on blue status, now we're on yellow, red, black, and purple status. I still don't understand what it means because I gave up, but it literally is, I'll come in and the board will say, we're on yellow, red, blue, and black. And I'm like, I assume this is bad. I mean, it's all 4. We don't have 3, we don't have 2, we have all, it is constant. When we don't have them, I just assume the system is broken. It's the NEDOC score. Has everyone heard that at some levels? And then it also brings in the hospital census and how many patients are coming in. It's just like, I don't have the bandwidth for this. I just know it's bad. It's going to be a rough shift. And we're going to have some problems. I better keep an eye on the waiting room because that means someone's going to code out there and I'm not going to know about it. So where does resident teaching come into this? We have increased medical error. We have staff burnout. And then we have all of our nurses leaving that we love because they're making a lot more money someplace else, like Utah. We have excessive costs, and we have increased morbidity and mortality. And I have a bunch of nurses coming in who are very nice, but I have no idea how they function. I don't know their names. By the time I learn their names, I really do try. They leave. They leave me. So like I'm left feeling a little unsafe, or before I felt much safer. This is a quote actually from my chair. And this was written a long time ago, so this is not a new problem. And I think this is actually a very real statement. And I think we can all agree that oh, hi, Dr. Kellen, he's right there. My chair is sitting right there. Hello. That emergency department crowding is a central indicator of health system functioning. And I think we can all probably agree on some level that the American medical system is not functioning optimally. We've got a lot of problems, and we are all very, very aware of that, because we see it every day. And how are we functioning in a teaching capacity? So this is not a new problem. And what hit me when I found this, because there's not a lot of literature out there on how to work with boarding patients, is this is from 2010. And this was a consensus paper written by a bunch of educators for CORD, all very wonderful humans. And this is 11 years ago. And I've always had the feeling that when we've talked about boarding challenges, it's always been like, it will pass. Someday this will not be a problem. We're not going to flex to boarding because it's not the new normal. And I was like, well, it is the new normal. It's been going on a really long time, from my first day of residency until now. And it was such a problem. In 2010, they wrote a consensus paper about it. And they identified the same exact issues that we are trying to challenge today. The educator, the learner, and then the institutional system, and trying to figure out how to make it all work together. And it's always a conflict. So the institutional wants you to move the patients, and the learner wants to learn, and the educator is stuck somewhere in the middle, getting lovely emails every month telling you how many patients per hour you saw and what your RVUs are. And I was like, well, how could I see 5 patients? The whole entire ER was at a standstill for 60 hours. I couldn't do anything. I billed a lot, but I didn't see anyone new. So core consensus is that we cannot control institutional goals. Yeah, we actually have a great relationship with our admin people. They're very much on our side, but we're very aware that they have very different stresses than we do. And inpatient staff, I think most hospitals, inpatient staff care for boarding ED patients. Again, that's a challenge for us. And should we borrow residents from other services, run codes on boarded patients? So if your institution, if the inpatients team take care of the boarded patients, do they run the code, or do you go in and run a code on a patient that you don't know anything about? That's a big stress, right? and continue teaching rounds. So we had challenges with this. Do we do rounds during COVID? Do we do rounds when there's patients in the hallway and they can hear everything we're saying? Or do we go back to huddling around a computer where it's super noisy because everyone's doing sign out, your nurses, everyone else, but you don't want to have teaching rounds with an audience? And yes, they had made comments before on what we're saying, so we're like, okay, we need to move. And I'm going to pass it on to Dr. Goldsam.
Sorry, we got to do a little switcheroo here. Thank you. Awesome. So I'm Katya. I'm from Yale, and again, we've obviously all had a lengthy discussion about these issues, and we're on sort of a text chain where we chat with each other over the course of the year, and have realized that we're all sort of facing these issues. But what we really wanted to know, just like Leah said, there's a lot of issues. How do we solve these? I think to be able to solve a problem, you first got to figure out what the extent of it is and what sort of the national landscape is. And she talked about the boarding landscape. I want to talk a little bit about sort of the education landscape and what we've found from a survey actually that we did via the Cord listserv. I couldn't figure out the SAEM listserv. It's a little more challenging. So this is actually a Cord listserv survey where we sent it out to essentially educators, hoping to figure out what you guys thought. I presume a lot of people here are educators, otherwise I admire your dedication for an 8 a.m. start for a topic that is not up your alley. But we wanted to figure out what everyone else was seeing, and whether this was just us. Is it just us sinking on this ship versus is everyone sort of on this ship with us? And are we alone in this issue? And then we wanted to see a little bit about what the changes are in sort of the clinical exposure that the patient or the residents are seeing. So are they seeing different patients? Are they seeing them in different locations? And how is that impacting their educational experience? And I will say this is sort of just a brief start. I think there's a lot more work to be done in this. But we wanted to, again, just kind of survey the landscape a little bit and see what was out there. And then we had a bit of a free text option at the end to see what other people have done. And we'll talk about, I'll talk about sort of the more demographic data now, and we'll talk about some of the solutions later on. So survey time. I know everyone loves surveys, so thank you very much. Anyone here who presumably is possibly also on the Cord listserv who filled this out, we really, really appreciate it. I know there's a lot of survey burnout at this time amongst other burnouts, multiple burnouts that we're dealing with, but so we obviously appreciate everyone doing this. This says SAEM. It was actually the Cord listserv. We had 69 respondents when we first submitted this April 1st. We actually have like 80-something now, so I'm excited to really analyze the final data. But I think you'll get a sense, at least in the grand scheme of things. So all over the country, we got a whole bunch of responses. Most of them were 3-year programs and academic programs, but I think overall, hopefully relatively generalizable, at least to those levels. So survey says, I don't watch a lot of TV, but Harvey something?
Steve Harvey.
Steve Harvey says, survey says, excellent, all right. That was obviously not my contribution. Defer to Becca on that one. But. So 79% of people said that they have boarding most of the time or always. So not only is it a big problem, widespread problem, but also a lot of the time. So it's something that we're facing, every day pretty much. In our department, it's been, I would say, pretty much every day. Ever so often, there's a day where there's no boarding, and you're like, what happened? All the patients actually went away, and that, it's sort of the rarity more than actually a common thing the way it used to be a couple of years ago. And then 95% said that it definitely affects education. And I should actually say that this is on a 5-point Likert scale. So for how much does it affect, or does it affect education, 95% said definitely, and 5% said probably, and basically no one said any of the last 3 points on the Likert scale. So I think we're all on the same page that this is definitely a problem. And then, as Leah pointed out, it varies by institution. Like, do you have ICU boarders? Do you have hospitalist boarders? Who takes care of these? And that's sort of an additional component that we wanted to figure out, because it obviously affects who the residents are seeing and who actually the patient population is in your department. And so 54% said that they board ICU patients half the time or longer. So again, it's a pretty big chunk of people that are seeing ICU boarders in their department. Thankfully, we don't really have 5 days of ICU boarding, but it's, I think, not an uncommon thing. So, more survey says Steve Harvey. 88% have inpatient teams cover boarding patients, so we're, I think, in the minority, or you're, I guess, in the minority. I'm grateful that we do have the hospitalist teams covering the majority of our patients, although it only happens, I think, at a certain number of hours. that has changed a number of times. But that was certainly a hard-fought win that I think has benefited the residents, that they're not busy running around taking care of inpatients, and thankfully not having to do med reconciliation and all this other stuff that we don't love as emergency physicians. ICU patients, about 50-50, are covered by the ED and the ICU. Our institution has sort of a combination where we essentially consult the MICU and they help us manage some of the patients, but we're obviously the primary person responsible. Certainly anyone that codes, I'm sure it's the same everywhere, like we'll obviously handle that. And then 35% think that boarding has led to us practicing, or the residents practicing outside the scope of their practice. So this was kind of a one question in here in the survey, but I think a really important one that probably warrants a bit further exploration in what this means philosophically. We had, when the workforce report first came out, we had a discussion with our residents about it, and one of the questions people had is EM really what the specialty that I signed up for? Is this what I'm going to be working in? And I think that certainly the boarding part of that has contributed to that. I don't know the answer, to be honest. I think even in the 10 years that I've been practicing, it's changed a lot. Like observation units, that sort of thing is now a common thing in many departments. And so I think the scope will change. I think the question is, how far out of that scope do we go in terms of teaching? Does it water down what we're educating our residents about, versus does it set them up for success in a situation where they are going to be dealing with a lot of boarders? So, again, I mentioned the med reconciliation. It's not something that we're very fond of, but if it's something that I have to do, I want to at least do it right so that I'm not, having a problem and doing it incorrectly and then putting myself and obviously the patient at risk. Versus the ICU boarders, we're maybe taking care of a lot more sick or critical care patients. That may be sort of a scope of practice that we're happy to expand. But so I think it's a little bit of a thorny question, and certainly one that our residents, I think, were concerned about as well. So that being said, 35% maybe not terrible, but actually a relatively high number considering, and I'm no medical legal expert, but certainly practicing out of what you feel like is the scope of your practice, I think is concerning and possibly stressful. Definitely stressful. So impact on your residents. We wanted to know, is it a big deal, and how much do you feel like it's impacting your residents? So again, this 5-point Likert scale, I think it was almost 80% felt like a moderate amount, a lot, or a great deal of impact was had on the education of the residents. So boarding, is it affecting it? Most definitely, and in a large amount, not just sort of a subtle impact, and 0% thought that it was not impacting them at all. So you'll see a lot of zeros in this not at all category. So yeah, 80%, as I mentioned, it's, I think, again, a pretty good consensus. So I wanted to look at specific areas, or we wanted to look at specific areas of patient care and residency sort of aspects of education, and how much these were actually affected by this. So I hope it's big enough, but the top one is managing high patient volumes, and the lower one is managing ED flow. So as we all know, this is a critical component of what we do as emergency physicians, is dealing with a lot of patients quickly and moving them through the department. And the 5-point Likert scale is at the bottom, so the orange and the blue are the somewhat negatively and extremely negatively impacted. So do you feel like boarding has impacted the education in these areas? So patient volume, managing high flow, certainly most people, I think it was 90% of people felt strongly that managing flow has been impacted, and high volumes has been impacted, and then almost 80 for managing ED flow. So that's again, a critical skill for emergency physicians, and this is now something that our residents are not really getting the exposure to in the way that we feel is important. And then types of patients that people are seeing. So has the education in these types of patients been impacted? And again, the orange and the blue is the somewhat negatively or extremely negatively impacted. And for undifferentiated patients, and then the management of fast-track patients, the top two ones, those are, again, people felt like that was definitely negatively impacted. And you can imagine the various scenarios that we use to sort of solve the problems of boarding, right? Is you have an attending in triage that puts in a bunch of orders, and then that patient is sort of started on that road, and the resident is no longer the first person to see an undifferentiated patient. I remember that used to happen occasionally when I was a resident, and we were frustrated by it, but it's become such a common thing in our department that it's sort of a refrain we hear a lot, that I just don't get to be the initial person to work it up. And I think it certainly changes the way that you're thinking about the patient as well. Similarly, you may have an attending or an APP or someone in fast track that's sort of scooping off, siphoning off the easy patients up the top. such as the fast-track patients. So the paronychia, I mean, we have plenty of residents that haven't done a paronychia in years, And that, I think, is something that's a huge deal because, again, the lower acuity is probably a majority of what we do in emergency medicine. So that's something where the location of where we're working has impacted the types of patients that we see. The management of ICU patients here, you see the yellow is the somewhat positively, so I think this is sort of, you're asking for one positive in boarding. I think maybe the exposure or the prolonged exposure to ICU patients is helpful, but again, sort of debatable whether that's something that we really want to be doing if it's technically out of the scope of our practice, and if so, how do we adjust our education to match that? And then diversity of pathology, people felt relatively neutral, so I don't think there's, you still see the patients you see, it's just the timing and the location may change a little bit. And then lastly, we wanted to know about the patient safety sort of QI component of it, whether you felt it was impacted by it. The reason we asked the question is it seems like, this is an operations admin nightmare in many ways. So maybe this is actually an opportunity to teach our residents about this. But speaking of which, a former one just stuck his nose out from the door. Anyway, so the QI part of it, maybe this is a great opportunity to sort of teach our residents about this, but I think people still didn't quite buy that, and still felt like that component was sort of negatively affected by this. So, lastly, the other question, I think this got sort of flipped around, but overall picture, this is sort of the big picture question, so those were the nitty-gritty of specific components that were affected by boarding, but 90% of us feel that boarding is affected by education somewhat or extremely negatively, and again, that's like a huge chunk, right? So not only how is it affected, but how much is it affected? I think the big picture is pretty obvious that we all feel like this is a problem, and unfortunately a problem that's not going away anytime soon.
Can y'all hear me? Babs. I'm sorry?
You need to wear the mic, please.
Okay. So one thing about being a residency program director is that we're beholden to so many people, the ACGME, the chair of the department, the residents, and the faculty. And so one thing I'm excellent at is following directions. So said, wear the mic, we're gonna wear the mic. So my job is to talk a little bit about how we're doing things differently now due to boarding, and talk about some challenges, and then talk about how we can do things a little bit better to try to augment our resident education. So how are our residents working differently? So now we're talking about working in different locations. So I'll be honest, so at our hospital, we had what was called a minor emergency department. It was legit 2 blocks from our actual ED. And if you needed to be upgraded to get like a CT scan or an ultrasound, you got in a van and they drove you the 2 blocks up to the ED. And if you had a real problem, like a stroke or something, they legit called 911 and you got driven to the actual ED from there. And so all of those patients were walk-in patients. And so you didn't actually they were self-triage, right? So a lot of those patients, they actually got siphoned off from our department. So about, I think 15 years ago, we got a new ED, and that's why that was built. It was never intended to be there long-term until COVID happened. So they saw about 20,000 patients a year, and we couldn't reabsorb them. So we ended up keeping the minor ED up until COVID, because then we needed central triage, so that you didn't have COVID all over the place. Although we have all since learned COVID went everywhere anyway, because everyone had COVID, even if you didn't come for fever, cough, runny nose, or anything that sounded like COVID. So now we had to create a fast track in our actual emergency department that didn't exist before because it was 2 blocks away. So now we've got to put residents in different locations than we did before. And so our fast track in our department has not moved once, but 4 times during COVID, and it will move again. So we're super excited about all the changes and whatnot, and what that does to resident education and faculty burnout. In addition to seeing patients in different locations, including the waiting room, including the hallway, including the little section off of triage, because if we could see it pull the staples out and discharge it from triage, we're trying that too. And so our residents are getting the experience of doing all those different things. We're seeing a different patient mix than we were before. So like we were talking about the fast track patients. So right now with boarding, guess who gets seen first? it's not always like the chest pain anymore. Staple removal probably gets seen first because it can be plucked off the top and discharged. Whereas before, it was a surefire thing. If you showed up to the emergency department with chest pain, you was gonna get seen right away. Not anymore. That's a level, that is an ESI 3, and you're probably gonna be the one who waits the longest at that point. There's a change in volume and flow. I feel like the volume is higher. In reality, I actually think volumes are back to where they were pre-COVID, but flow is so bad because of boarding that the volume feels worse because you get to sit there. There's nothing like being the 2 o'clock attending and you just watch the lobby blow up. Like there's just, it's like, oh, it looks manageable, there's 10 people, and then by 5 o'clock you're like, oh, there's 60 people in the lobby and I can't do anything about that. So there's been a change in that. There's been a change in acuity. I don't know how everybody else is feeling, but it feels to me that everybody is sicker. That it's like they didn't get to see their doctor for the past 2 years, and so now problems that maybe were well controlled pre-pandemic are now way out of whack. Or, you know, now it used to be the patients who like never saw the doctor that came in, their stuff looks all kinds of crazy, but now it's patients who used to be well followed but can't get into the doctor for whatever reason, and so now things that like their CHF exacerbation, maybe their doctor would have gone up on their Lasix as an outpatient, but that didn't quite happen, so now we're seeing them on BiPAP, we're seeing them hopefully not needing to be intubated but needing some sort of respiratory support and things along those nature. So I feel like there's a change in acuity. As Leah said, we're managing inpatients. So I am really blessed our inpatient service, as soon as we call them, when they decide that they're admitting the patient and they put in admission orders, it turns purple. We don't have to think about them anymore. We actually don't sign them out anymore. So if you're sitting on our board and you are admitted to the hospital, I am very unlikely to know anything about you, which is a big difference. So pre-COVID, we would sign out the entire board. If you were admitted, if you were pending a consult, if you were a new patient, you got signed out on the entire board as the attending. Now, because they've been boarding for so long, we don't sign those patients out anymore because what we were finding was that once you've been there 2 days and this person's signing it out to you, they don't know why the patient got admitted either. And then the patient's like, well, what's my care plan? Do y'all know the care plan? Because I didn't, because the inpatient team had already changed the care plan 3 times since they got admitted, and so we found ourselves causing more problems trying to mitigate some of those circumstances, so we actually don't sign those patients out anymore, which makes it lots of fun when they code, but that's a different conversation. And then managing ICU patients. So we actually manage our ICU patients until they go upstairs, but luckily our ICU is really good about turning over the beds if they're downgrading people or whatnot, so we're not keeping them for days on end. But I know personally, I've had to start 3 pressors on someone, and I'll be honest, like we've now maxed out Dr. Bradby's capacity to know anything else about how to manage this patient. When I got to the pressor, hello, ICU, I need you to actually come down and manage this patient. I'm gonna give them credit for being awesome about coming down to help us out, like when we're like, I tap out, don't know anymore. But how does that affect resident education? Like, it's been a lot of fun to tell my residents things like, you know what, I don't know. We're gonna have to phone a friend. Like, this is a great use of the telephone. So they have learned some humility on that one because I'm really good at saying, I don't know. And I actually think that's probably safer for patient care. So they've learned, I think, a lot more about that as well. So some challenges, I kind of talked about this some. So changes in acuity, we got some sicker patients. We're managing inpatients, so we're practicing outside of our normal scope. We're managing ICU patients for longer while still trying to manage the flow of the ED. And so, you know, once you get to the 3rd pressor and the patient is still kind of not doing so fast, you're probably not leaving the bedside. And so then what's happening to the rest of your room when you're on the 4th hour of this resuscitation? Like, that is a problem. Whereas before, that patient would already be upstairs somewhere and somebody else would be at the bedside managing it. And then in terms of education, like, where do we find the time and the resources? So while we're dealing with higher acuity and trying to figure out flow and trying to keep an eye on the lobby, because there's nothing worse than the lobby code or the lobby seizure or the thing that got videotaped and put on the internet because the patient was acting up in the lobby and nobody knew about it, that kind of stuff. So trying to manage all of that. Where does education fall in while you're trying to do all of this as the attending? And so let's be real, it's probably the first thing that falls to the wayside. So as we start thinking about that, we're going to talk about like the impact on clinical care and flow, the impact on on-shift teaching, changes to the staff dynamics, because let's be real, I don't know 50% of nurses right now, which is hard for me because I'm a busybody, if you can't tell, like that, it's my thing. I love knowing everyone, where you're from, what it is, and I can't do that anymore because the nursing turnover and the staff turnover in general is actually just too high for me to do that anymore. everything seems to be a moving target. Our strategy on how we're going to move our department changes from week to week. And so at the beginning of COVID, that was lots of fun because we would shut down parts of the ED because there wasn't enough patients towards the beginning of the pandemic. And so you would get a phone call the day before you're supposed to come to work. Hey, so-and-so, do me a favor. You're going to be first called tomorrow. If we have a surge thing, you'll come in. Let's be real, that was never going to happen. But you don't have to come to work tomorrow. You are now off, but you can't drink because I might need you if anything goes wrong. And so every 2 days, we would have to reassess if we were going to open whole sections of the ED. And so you can imagine how difficult that was, not only for kind of staffing, but like trying to live your life on whether or not you had to go to work and everything in between. And then lastly, like, let's be real, everybody's just tired. I really will tell you that I was super naive going into this. Like, coming into the pandemic, I was like, all right, cool. Like, it's a viral thing. Hopefully it won't be forever and ever. Yeah, I was so wrong. So like now we're in year 3 somewhere. It's not getting any better. It's different. It's getting different, but we're still having the same problems that we've been having for at least 18 months. And I think it's important to recognize that our residents are feeling the same things we're feeling. So the current graduating class will be the last class that you've had if you're a 3-year program that remembers what practicing in your ED was like before the pandemic. They were interns. So now that means every class you have under that has only been a doctor in the middle of the hot mess that is COVID. And so they too are exhausted, they are tired, and I think it's important that we remind them that they are not alone. And so one of the things we've noticed in terms of barriers and gaps in education is it's actually harder to teach at the bedside. If y'all remember at the beginning of the pandemic, you couldn't take everybody to the bedside to see the patient. Like if you were used to take your med student with you, be like, hey, come see this interesting finding and stuff. Couldn't do that anymore because there wasn't enough PPE for all of that. Now we're like talking about lack of physical space. So like you can't bring in a whole team to do things. And then if you're thinking about like, contact precautions and all that kind of good stuff, respiratory precautions, do you really want all the people in the room trying to do kind of some bedside rounds like in the middle of breathing in the Rona? Probably not. That's probably not a great idea. In terms of like high patient volumes, we're trying to turn over a room that we can't entirely turn over. And I think that's been a little bit harder as well in terms of our teaching. Staffing changes has caused issues. So you've got fewer nurses per patient. You've also got increased travel nursing. You've got brand new nursing. We didn't write that, but we have a whole lot of new grad nurses. So all of those experienced nurses that used to save our butts in the middle of the night, like, the ones that are like, hey, that patient looks a little funny. You're like, yeah, that's anaphylaxis. You're right, that does look funny. Let me go get some epi. Those people are no longer there. And so now we're not only having to learn new staff, but we're kind of having to train some new staff, right? Like getting to know our new nurses, getting them acclimated to the system, how to work with us, that kind of thing. And so that has been like a particular challenge during this. And then I will tell you one of the things that I found most annoying was 1 month prior to COVID hitting, our hospital let go a whole bunch of ancillary staff. So we're talking cafeteria folks, the folks who drive the shuttles, the folks who do valet parking, EVS staff, facilities management, like the ones who patch the holes in the walls and change the light bulbs. They got rid of, I think, about a quarter of them, if I'm not mistaken. So we went into the pandemic with less ancillary services than we did before, and that was all right at the beginning because we didn't have a ton of patients, remember? But as soon as volume started picking back up, the next problem we had for boarding wasn't even that there wasn't enough beds, there wasn't enough people to clean the beds. So you couldn't get the beds turned over in order to get patients upstairs. And so having to deal with fewer ancillary staff to help you do the other things that you think about in terms of trying to take care of your patients has been a big problem. In terms of APP staffing, we actually have less APPs in our department post-COVID than we did before. As there has been a lot of discussion, y'all noticed this year we had 217 open residency spots after the match. There's less people choosing emergency medicine to some degree. There's less APPs deciding to stay in emergency medicine. And so we're having to try and hire new APPs to try and fill some of our gaps, which means training them as well, kind of similar to the issues we're having with nurses. And then on top of that, we have fewer attendings and residents to some degree because we've had multiple people out sick at a time where that never used to be a thing. Like, can you guys actually remember a time when you'd have 5 or 6 people out, like, due to an illness? I know when I was a resident, like, we came to work runny noses, coughing, vomiting, which was not a good idea, but I definitely know I did it once. So, like, was that a good thing? No, that was a bad thing. So if anything, one nice thing about COVID has been doing a little bit better self-care and taking care of yourself when you're actually sick and not coming to work. But the problem with that is that we still have to cover all the shifts and we still have to see all the patients. And so there's more people working more shifts is what it feels like because we're trying to fill the gaps with those who are missing. Which has led to some fatigue. So if y'all didn't see it in the 2022 Medscape survey, we won the award as a specialty as the most burnt out specialty. 60% of emergency physicians who filled out the Medscape survey said that they were burnt out. Which, you know, when you're tired and overwhelmed, your enthusiasm for teaching decreases. Surprise face! Because your enthusiasm for legit everything has decreased. So in light of that, what do we do? So some stuff to help. We've been talking about using some different teaching strategies in the department. So some different approaches to like some bedside teaching. So maybe if you have a room that's got a door and you're not suspecting Rona, you can now bring the patients back to, you can bring the people back to the bedside. It's a great way to try and do some different communication strategies, follow up with your patients in terms of what did they understand. We've been trying to focus a lot more on communication because I feel like in addition to us being tired, the patients are also tired, and I almost feel like it's a little bit harder to meet their needs and their expectations now than it was before. And so focusing a lot on communication at the bedside more so than we had before. In terms of procedures, I've noticed that procedures changed, and so I'm pretty sure all of you have also noticed this. We're not doing LPs at the rate we were before, and that includes pre-COVID, right? So pre-COVID, we weren't doing them as much because CTAs and all that kind of stuff came in, and so like now we're not like tapping subarachnoids the way we were before. But then when COVID hit, there was no longer neonatal sepsis workups because they weren't getting sick. There was no neonatal fever anymore. You weren't seeing as much like viral meningitis and things like that. So the numbers of some procedures actually has gone down during pandemic times. And so trying to find ways to teach procedural skills that we're not getting at the bedside the way we were before. So our night teams have actually started hoarding like old expired kits. And so when they have some downtime, they go over the more rare procedures in our workroom to get some extra practice. So trying to use some of the downtime that we didn't have previously. Doing some team-based strategies. So if you look at the 2010 consensus statement, they talked some about being purposeful in kind of how you highlight teaching. So here is the teaching point on this case. During sign-out, here is the teaching point about this interesting patient we just admitted. Being purposeful about saying like, hey, it looks like we're all locked up. Let's take 5 minutes and like go over something on the whiteboard. So here's some teaching points. We just saw this, our acutely ill patients are called medical yellows, like the ones you guys see immediately. So we just had this resuscitation. Let's talk about the management of acute CHF with pulmonary edema. And so like kind of highlighting those things really quickly. And then the other thing that we had been talking about was looking at workflow strategies in the hospital. So how can we rearrange things to best maintain our abilities to educate our residents? And so one of the things that we've been talking about is like, can you move times? Like, can you move shift times? So you notice that boarding is worse during what used to be the peak time in the emergency department, right? You needed more people kind of on that swing shift to manage the uptick in patients. Well, now there's no turnover during that time, so should you change the shift times to try to accommodate when you know the flow is gonna increase? So in my department, at about 7:30, when the night nurses take over, they somehow talk to the floor nurses and mass exodus, like 20 people at a time, and then re-room everybody. And so would it be better to have extra coverage between 6 p.m. and 1 a.m. where you're going to have more turnover than you did between 2 and 6 where you used to have more flow? So looking at kind of timing of how you have shifts or when you have extra people, I think also helps. In terms of teaching strategies, we talked some about our core concepts of EM clinical education. And so we used to focus a lot on flow in terms of into the department and then back out of the department. Now we're not seeing as much of that out of the department other than kind of discharging people. So how does that work? Like, and then discussing with them, like, I have to talk to the residents a lot about like what it looks like in the waiting room. Don't forget such and such. Can we send somebody to triage to see these patients? Can we send someone out to, like, we have like a 6-chair area next to triage. Like, do you guys think we can upstaff this right now since we can't turn over our other beds? They're like, well, I would really like to not see head bleed in the chair. I was like, head bleed in the chair is better than head bleed in the lobby. So, you know, looking at it that way. And then looking at presentations. So I have actually realized that I've been hearing less presentations in the past 3 years than I used to. So, because they're seeing less individual new patients, like on a shift. And I didn't quite realize this until we were doing direct observations of the residents. So we like to do 2 hours direct obs in a shift and follow the resident around, see what you're doing. Like, how do you talk to the consultants on the phone? How do you how do you tell your patient what's going on? How do you let them know that you're going to admit them to the hospital, that kind of thing? Looking at communication and efficiency and whatnot. It's actually been a lot harder now because if you're only seeing 1 patient an hour sometimes, 1.5 patients an hour, I can't really tell you a whole lot about your efficiency because you're not moving enough stuff for me to talk to you about it. So having purposeful conversations about workup and diagnosis, being a little bit more thorough about the differential since now you have all the labs from the lobby so you actually know what the diagnosis is. So now we actually have to purposely ask you to tell us. I'm going. Talking about your presentation skills and then being purposeful about asking more about their thought process and whatnot that you didn't used to have to ask before because now they have all the stuff back. And then a lot of this is pretty much stalled because, you know, all of this messes with our usual teaching paradigm, so we have to be a little bit more purposeful about how we're going to do that. I talked a little bit about this already, but I think one of the things that we have to remind our residents is that this is a marathon and not a sprint. Whereas I went into the pandemic thinking we were going to sprint through this bad boy, but clearly I was wrong, so disappointment. But when we asked folks what they've been doing, we talked some about like moving locations, so pods, seeing patients in the waiting room, maybe moving them to other EDs, changing shift times, and then waiting room evaluation teams. Like, apparently the lovely folks at Akron General are trying this. Like, I am terrified of the waiting room, so I wouldn't be super enthused about it, but hey, I think that's a great idea if you can accommodate it. And then they're also looking at different ways to reduce attending and resident staffing. So that's either increasing APPs. They've started something called ET3. So EMS actually calls in for a low acuity patient and tells them, you know, I think this would be a good telemedicine patient, and they actually send them to do a little telemedicine phone call with EMS at the bedside and then prevent bringing the patient to the ED at all. So that's less patients in your department. And then they've also created something called urgent dispatch. So this would be a patient that you would generally admit to OBS, but now you don't know, they have a way to send you home and have a doctor come to your house, see you, give you fluids and all that kind of stuff the very next day, which I think is really awesome and could actually be like a different kind of education modality if you really wanted it to be. There's been some increased use of SIM because small groups were safer theoretically during COVID, so increasing that. You could have ICU surge teams, so having teams that literally see your ICU patients in the department, like ED-based teams, but they're taking some of that clinical load off so that you can focus on flow more than managing the one that's been there for 4 hours. And then having residents in triage, so we haven't moved to that point yet, but we do have like staff in triage, usually attendings, and so like what I've noticed is that that's going to be a big thing going forward. It's at a lot of community hospitals and a lot of academic centers, and so they're going to need to learn how to do that. So how do you incorporate your residents into triage management? And then bringing them to the table for clinical operations discussions, because anything that ClinOps does is going to affect our residents and their education. And so having them have impact, like having some input at the table, not only increases buy-in, I actually think that a lot of the things go over a lot better when the residents are hearing it not only from me but from each other and how they came to that decision. And so I think that helps a lot, honestly, with wellness. Overall, we need to prioritize teaching patients. Review our patients with our residents, like looking at morning rounds, and then continue to like try to be emphatic about our current bedside teaching methods as best we can. And then lastly, one of the things that we had talked about were like what does this look like in terms of the milestones going forward? And I think that's something that needs to be looked at in terms of further research, because like now we're going to have some limited like ability to evaluate folks on not only efficiency and multitasking, but thinking about performance of a focus, history, and physical, because we're not hearing as many of them, and the patients are already coming pre-worked up to us, which also kind of reflects scientific knowledge. And then on top of that, like we might actually see an improvement in terms of patient safety and quality improvement, because every single time we change something in the department, it's a new quality improvement initiative. So how can we get our residents involved in that? And then when you think about kind of students like entrustable professional activities and like thinking about competency-based learning, how has this been affected for the students as well? So things to thinking about going forward based on boarding.
Okay, we're gonna fly through these last slides in the sorry, next 3 or 4 minutes. See if I can do that. Okay, so my approach to this is a quote that is, being challenged in life is inevitable, but being defeated is optional. And I think that's kind of how we had to go a little bit into the pandemic. So I'm gonna take the last 5 minutes to very briefly say, can we use this to our advantage? What can we innovate? What can we do to actually enhance teaching? Because this is, the future, this is who we are. So one of the best things we did was get a whiteboard, and we started by looking at, again, don't tell anyone, right? The Cleveland Clinic wanted like $800 to order a whiteboard through their service. So we did what any good person does, we Amazoned it. And then we built it ourselves for like $60. And this has been absolutely amazing. Every single shift that I come in, something new is on that whiteboard. And I think it's increased our environment of inquiry or whatnot on the surveys. But it takes some time where we really do learn, really do just a few minutes of clinical teaching, even in the busiest of settings. Multitasking, helping the residents to learn to move patients through a really busy time. So we've flexed to other places, which she kind of mentioned. We have some freestanding emergency departments, and they have increased their volume, and it's been fantastic for our residents to learn and to go out there. Virtual visits and clinical decision-making units are other ways also. Team management, we talked a little bit about this, but you are the good example of teamwork. So you need to be there. The example you set working with new nurses and with travel nurses, the residents pick up on that. And then, of course, learning to do, so we laugh about this, our waiting room evaluation team is a physician and a nurse, and unfortunately has the nickname of the wet nurse. So the job of the wet nurse and the doctor are to identify those potential sick patients. So teaching residents, this is a great opportunity to teach them an ounce of prevention is worth a pound of cure. So it's true. Look at your department, look at your waiting room, know who's gonna code. It's good. It's a good skill for the residents to have. So have them take that ownership. And then increase communication, sign out, talking to consultants. This is a great time to teach that more and better for those residents. Sorry, I'm going quick so we can finish. And then this is a great time to teach QI and patient safety, and empowering your residents to be part of that solution. So we did 2 things this year that were great. We had a mock RCA, so we had all of our residents participate in an RCA and learn sort of the systems practice of that. And then we had a mock trial. So one of our attendings is named Jano, and he was Judge Jano, and he did a full deposition on a real patient with one of our residents in front of everyone. And I think it was a great experience for them. It was really a moment to reflect upon. You have to be careful how you practice and how you document, not even careful, but just thoughtful about how that can reflect back, and to learn the bigger process. And then lastly, be flexible. So I think this has been really important for dealing with boarding and dealing with wellness in general. So we're from sunny Ohio, where it was predicted, I think, that we're supposed to get 6 inches of snow, and then we got, 15 inches of snow overnight, and they just didn't plow. So you know what? We took advantage of that situation. Now that we know Zoom, we sent out a funny email the day before. We gave them a quote-unquote snow day, and we had virtual conference, which was great. So really play to that strength. Use humor. Humor is a positive way to deal with stress. We also met outdoors, so we've had wilderness days, we've met outdoors, we've kind of gone with the system. And then work within the system. So we have our we have our residents present in QI, they come to GMAC, they're really present at all of the decision-making boards in our hospital, which I think is really important to empower them and make them part of that system. So I think we are kind of perfectly on time. All right. So a couple conclusions and recommendations. I think we definitely talked at length about what boarding and what COVID how it has impacted our residents and our teaching. But I think we've made a lot of changes, and being adaptable and using that to your advantage, and realizing that these residents need these skills because boarding is not about to change is really important. So right at the end, thank you all for coming. And if there's any questions, let us know.